The following program has been made possible by an educational grant from Bayer Healthcare Pharmaceuticals, Inc.
Welcome. My name is Dr. George Kraft, and I'm the host of this year-long monthly TV series on multiple sclerosis. This is the sixth in the program, MS from A to Z, and this topic is on fatigue and pain. Our speaker today is Dr. Don Ehde, and Don is a member of our Multiple Sclerosis Rehabilitation Research and Training Center team. Her expertise is in pain, and we also are going to talk to you a little bit about fatigue. And I want to mention to you that fatigue was not really in the medical literature with regard to MS until 1984. And it was research from this center that published the first paper on fatigue in MS. And now everyone who deals with people with MS and patients with MS all know that fatigue is the most common symptom they have. So it's a great pleasure for me to introduce Dr. Don Ehde, who is also the principal investigator and the mentor for our multiple sclerosis research fellowship at the University of Washington. Don, thank you so much for agreeing to talk today.
As Dr. Kraft said, I'm going to be speaking to you today about pain and fatigue in MS. First, I'd like to acknowledge several sources of funding for us. This includes our Multiple Sclerosis Rehabilitation Research and Training Center. Also, some of the findings and ideas that I'm going to be presenting here today are based from a pilot study a colleague, Mark Jensen, and I did that was funded by the National MS Society. I'd like to acknowledge the many co-investigators that have made my research and work in the areas of pain and fatigue possible. And those include Mark Jensen, George Kraft, Kevin Gertz, Brenda Stold, Tiara Dilworth, Adam Hirsch, Ivan Moulton, and Travis Osborne. We've had quite the team who've really been studying the problem of pain for the last 10 to 12 years. And also we have staff that have been very helpful in our studies, and those include Kara McMullen, Laura Henderson, and Jamie Wazenkowitz. And finally, throughout my slides today, you will notice that I've included some pieces of art. This art is from an exhibit called the Pain Exhibit, and it's curated by a Mr. Mark Collin, who is someone who has pain, and many of or all of the artists in the exhibit, the pain exhibit, have pain themselves, and several have MS pain. So I call your attention to the website, and I'd like to extend my thanks to the pain exhibit for allowing me to use some of their art to really portray what sometimes is hard to show in words. Today I'm going to be talking to you a little bit about just what is pain, specific to MS. I'll also briefly touch on fatigue, give you an overview of that, and then move on to talking about the prevalence, the impact of pain. I'll go into some detail about biopsychosocial factors that influence how people do who have pain in MS, talk a bit about assessment, and conclude with a discussion of various treatment options that exist for treating pain as well as fatigue. Now, as you can see in this slide, MS is really a complex experience, and the MS experience includes not just the sensory and physical and cognitive symptoms that come along with having MS, but also a number of other domains, including problems with fatigue, problems with sleep, cognitive problems, depressed mood, which I believe one of our other series shows by Dr. Bombardier covered, and also today's topic, pain. And all of these factors are not, they do not influence the person with pain in isolation. They all interact and overlap and really make for a number of hidden disabilities in MS, as well as really a complex picture of symptoms and experience. I want to just briefly touch on fatigue. Fatigue affects as many as, and possibly more than 80% of people who have MS. There are essentially two ways of thinking about MS fatigue. There's what we sometimes call primary MS fatigue, and this is caused by direct damage to the central nervous system itself. And this is the most common type of fatigue often thought of when discussing fatigue in MS. However, we know that there's also secondary factors that result in fatigue, and we sometimes refer to this as secondary MS fatigue. And these are brought on by a wide variety of sources, including other physical or emotional changes, external factors in the environment, etc. Just to go on to expand on that a little bit more, several secondary causes of fatigue include other medical conditions. People with MS often have conditions besides MS, or can have conditions besides MS. And so other chronic illnesses, infections, or injuries can lead to fatigue. Sometimes medications have side effects that can contribute to fatigue. We also know that sleep is very disturbed in persons with MS, and when you don't sleep, you tend to have more fatigue. People who are depressed also tend to have more fatigue. So there's just a number of factors that can lead to fatigue in MS. We also know that just prolonged chronic stress, does affects how people feel and their energy levels. Things in the environment, lighting, temperature, or just having a lot of chaos or disorganization can contribute to fatigue. And then finally, many people with MS are limited in what they can do and sometimes suffer what we like to refer to as superhero syndrome, where they maybe try to get a lot of things done because they're used to being productive members of society and of their families, and sometimes just do too much and as a result have more fatigue. I'll come back to fatigue a little bit later in my lecture, but now I'd like to focus on pain. And first, what do I mean by pain? Well, pain has been defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. And what I'd like to point out about this definition is that pain is not just a sensory experience. It also involves emotions, it involves behavior, and I'll talk more about this as we proceed today. Another definition of pain that I really like by Margot McCaffrey is, pain is whatever the experiencing person says it is and exists whenever he or she says it does. And throughout my talk today, I will be talking about a variety of factors that influence pain, but underlying all these factors is the general idea that pain is very real and that the person's experience of it is key to understanding it. I want to briefly touch on acute pain. By definition, acute pain lasts for a limited amount of time. It's usually preceded by a clear event or some sort of precipitating reason for the pain. It tends to be very specific in location. So some examples of acute pain are things like appendicitis, dental pain, a sprained ankle, or in the case of MS, pain from an acute attack of optic neuritis, where a person might experience pain in the eyes and where movement may exacerbate the pain. Now, chronic pain, by definition, is chronic, and by that we mean it lasts typically more than 6 months. And while it may not always be consistent in that people may not necessarily experience pain every moment of the day, typically they experience pain more days than not when having chronic pain. It's usually due to non-life-threatening causes, and typically has not responded to available treatments and hence is chronic. And some examples of chronic pain outside of the area of MS include chronic headaches, things like migraines or tension-type headaches, chronic low back pain, arthritis, or in the case of MS, there's a number of types of chronic pain people can experience. Finally, I'd like to distinguish between neuropathic pain and musculoskeletal pain. And neuropathic pain is caused by changes or damage in the central nervous system itself. And sometimes people refer to this as nerve pain. But people can also have pain from other sources, including musculoskeletal pain. And this comes from problems in the muscles, the bones, the ligaments, or tendons. And oftentimes musculoskeletal pain can come from changes in how people move about as a result of the effects of MS, from inactivity and a variety of other sources. I think what's important to take away from my descriptions of pain is that pain is really a multidimensional experience. And as shown in this slide, there are emotional and affective components to it, cognitive components to it, nociceptive, which pertains to the actual nerve input or sensory input into the nervous system, and nociffensive, which refers to some of the actions that we do reflexively or in response to pain to try to avoid or get away from pain and deal with pain. And there's a nice review of how our brains and central nervous systems process pain by Neuroberger in 2009, as referenced on your slide. But in that article, they really review, based on kind of our current understanding of pain in the brain, all the various areas of the brain that contribute to the experience of pain. And it is much more than just a simple sensory experience. So pain, again, is multidimensional. It includes not only how much a person hurts, but it also includes location, intensity, or kind of how bad it hurts or how severe, as well as duration and frequency. These are all dimensions that are important for you to pay attention to if you have pain or are working with someone with pain. We also know that pain results in affective distress, and by this I mean the emotional arousal and disruption that can come from having pain, or how bothersome it is. And finally, pain results in disability, or can result in disability, including interference with activities and participation in activities that people value. Now, outside of MS, chronic pain is very common in the general population. In fact, it affects more Americans than diabetes, heart disease, and cancer combined. And it's estimated that 9% of the US population has moderate to severe chronic pain, with low back pain being the most common, followed by headaches, neck pain, and facial pain. And most recent estimates for how much pain costs us as a society is that in the US, the annual economic cost is as much as $100 billion. Now, turning to chronic pain and multiple sclerosis, we know from a recent review by O'Connor et al. In 2008 that chronic pain affects as many as 20% of people at the disease onset, 50% at any given time, and 75% of people who've been surveyed and asked about the preceding 3 months. So we know that pain is very, very common. And unfortunately, pain used to be thought of as MS used to be thought of as a painless disease. But research done here and in other places has shown over the last 10 to 15 years that is not true, and that, in fact, pain is unfortunately very common amongst those living with MS. Of those with MS-related pain, around 25% report their pain as severe. And unfortunately, many people with MS live with pain in more than one site. So it might be in multiple locations at the same time. It might have multiple sources and multiple characteristics. And we know that pain causes suffering. As shown in this picture, living with chronic illness and pain, this art depicts what it might be like for some people living with pain as they look out at a world that they want to participate in, but too often is limited by their pain. We know that people with pain tend to have greater physical disability. They tend to have more difficulties in terms of emotional functioning. They tend to be depressed, more depressed than persons without pain. And they tend to be less able to do the things they want to do. So pain causes suffering. Now let's turn now to some of the models for understanding pain that exist. And traditionally, pain was viewed from primarily a biomedical model of pain, where it was thought that an underlying disease or injury, some sort of damage, had a direct cause to the experience of pain. And it was thought that if you could find the source of that pain and treat it and cure it, pain would go away. Now, this model works well when we're talking about acute pain, things like a toothache. You fix the abscessed tooth and the pain tends to go away, or you have a fractured limb, you fix the fracture, and over time the pain goes away. Unfortunately, this biomedical model fails for people who are living with chronic pain. That doesn't mean that there aren't biological risk factors that influence how people experience the experience of pain. And certainly, there are certain neurologic risk factors. People who are older tend to be at greater risk for more pain. People who are less active or deconditioned, which can often happen if you have a fair amount of physical disability, those people tend to have more pain. Also, people who have a lot of acute pain early in the course of a chronic pain problem tend to have more severe pain. And the more sites of pain you have, the worse you do. However, there are a number of limits to this biomedical model. As I mentioned earlier, it works well in an acute model, but it doesn't work as well when trying to understand chronic pain. And pain is one of the limitations of biological-only models is that pain is too often only treated with medications. And as I will talk later on, medications certainly have an important role in treating pain. However, they too often do not result in adequate pain relief, and there are a number of other treatments that warrant utilization when a person develops chronic pain. And on this slide, you will see some art. It's called Happy Pills Ain't So Happy by Mark Collin, and it's crushed in whole Wellbutrin, acrylic media, and charcoal. And it really illustrates that oftentimes medication is not sufficient in treating chronic pain. So let's turn now to what's really dominating the field of pain science, or the pain science field, and that is the biopsychosocial model for understanding pain. In this model, biological factors, psychological factors, and social environmental factors are all thought to interact with one another and also to influence how much pain a person experiences, as well as how they do in terms of their well-being, emotional and physical well-being, their functioning, and their participation. And this is really an integrated model that incorporates all of these various processes and really views pain as a dynamic and reciprocal interaction amongst all of these factors that shape how the person experiences pain and, as you will see, how it is treated. We recently completed a review of psychosocial factors in MS pain here at the University of Washington, and we found that similar to the general pain literature, psychosocial factors are significantly associated with pain and dysfunction in people with MS pain, even when you control for clinical and demographic variables. So even if you control for the type of MS, the severity of their MS, other factors, you see that psychosocial factors play a very important role in understanding MS pain. And you might ask, well, what are some of those factors? And that's what I'm now going to cover for the next few minutes. Important psychosocial variables in chronic pain include cognitions, or how people think about pain, their beliefs, how they cope or respond to pain, their activity level, including problems with pacing their activities, their mood, and their social environment. And let me take on each of these for just a few moments. In terms of cognitions, what I'm referring to is what people think. All of us throughout the course of any day have a number of thoughts that come into our mind, and oftentimes many of these thoughts are very automatic, and we don't even realize them, that they're not necessarily something we really consciously work to experience, but just a variety of thoughts in and out through our days that we may or may not necessarily be aware of. And that's what I mean by cognitions. I'm not necessarily talking about the kinds of cognitive problems people might experience in MS, such as with attention or memory or problem solving, but really just that kind of internal chatter that we all have going on in our heads throughout the course of the day. And these two people really said best the importance of thoughts in understanding pain as well as other aspects of human functioning. And Henry Ford was quoted as saying, "Whether you think you can or whether you think you can't, you're right." And William James, who was a pioneering psychologist and philosopher who himself experienced illness throughout much of his life, said once, "The greatest discovery of my generation is that a human being can alter his life by altering his attitudes." Let me just tell you a little bit more about this to hopefully make this clear to you if this is a new concept for you. So let's just look at this diagram for a moment, where you see that there is an event. Anytime one experiences an event, we tend to have what's called an appraisal of that event, or we tend to think about it and evaluate it. And what we find is that people can have generally two different tracks of appraisals. One is a negative or an unhelpful interpretation of a situation or event, and the other might be a neutral or even a positive or helpful interpretation. Well, science has shown us that when people have a negative or unhelpful interpretation, it leads often to a negative emotion, Whereas in turn, when people have a neutral or positive interpretation, it leads to a neutral or positive emotional response. So to put this into real concrete terms with an example, let's just imagine someone who has MS, who has a pain flare-up. If this person says to themselves, "I can't stand this, I'm never going to get through this," they are most likely to experience emotions such as frustration, hopelessness, likely experience an increase in their pain, and likely become less active. However, another person, if they have a pain flare-up, might respond differently, and they might appraise the situation in this way. They might think, I've been through this before, I can manage, but I know I can manage my pain, and I need to just do something about it. I need to distract myself, or I need to use some of my relaxation skills to take control of the situation. People who go in that route tend to feel typically calmer, more hopeful, or perhaps they're more likely to decide to engage in pain management activities that are going to help them manage their pain. Now, the reason that I'm presenting this information about the importance of cognitive factors is because, interestingly, numerous studies throughout both MS as well as the broader pain literature have shown that it is one of the most, if not the most important factor that influences how a person does when they have pain. And within that realm of thoughts, we know that one thought in particular, pain catastrophizing, is particularly problematic for people when they have pain. Pain catastrophizing can be defined as excessively negative and unrealistic thoughts about pain and one's ability to cope with it. So as in my example, it's thoughts like, "I can't stand this, this is awful, this is overwhelming, I can't deal with this." These kind of catastrophic thoughts are known to be highly associated with poor outcomes in persons who have pain. And in fact, they're the strongest and most consistent predictor of adjustment to pain. And we've replicated that in persons with MS. We know that in MS, people who have these catastrophic thoughts in response to pain tend to do worse, not only in terms of their level of pain, but also in terms of their physical and psychological functioning. So let me just give you a case example from someone I once worked with who has MS. She's a 44-year-old woman with relapsing remitting MS, 2 preschool children at home, and she has ongoing chronic pain. And the situation that she brought in for us to work on together was she woke up in the middle of the night with severe pain in both of her eyes. And she told me, because she was tracking this as part of her treatment with me, that she told me about some of the thoughts she had in response to that pain. She started to think, "I'm having a severe optic neuritis attack. I'll have to get treatment tomorrow. The children will have to go to their grandparents' home during the day." And she said those kinds of thoughts were not all that unhelpful or harmful to her because they were realistic. She would need to do those things. But then she went on to say that she started to worry that something more serious was going on with her health, and having thoughts like, "What if I have a serious disease? What if I'm having a stroke? How will my family make it if I die as a result?" And she said the more she laid in bed and thought those thoughts, the more pain she had in her eyes, as well as then her ears, more physical tension. She had more paresthesias in her legs and arms, and she started to have painful spasms. She also felt very fearful and very sad. And she was able to really tell me about this as a result of our working together and her learning to write these things down. And I'll come back to that case example a little bit later in my presentation, but now I want to talk about another type of psychosocial variable called pain beliefs. These are defined as an individual's beliefs about pain and its meaning to their present and future goals. And we know that there are a number of adaptive and maladaptive pain beliefs that can help us understand chronic pain. Some of the maladaptive beliefs include that pain is constant, that pain equals harm, that there is a medical cure for pain, and that others should be solicitous in response to pain. And by that I mean people who believe that other people should wait on them or do things for them because of their pain tend to not do as well. They tend not to be as proactive as people who have different beliefs. Adaptive beliefs include the sense that one has some control over pain and its impact on their lives. The belief that they have self-efficacy, which means that they believe that they have the ability to control, again, or master or manage their pain. and just people who in general believe that they can have some control, and that tend to know what they can control and not what they can't control, tend to do better when it comes to the experience of pain. Turning now to pain coping. By coping, I mean behavioral or cognitive efforts to manage pain and or its impact. And some examples of this are when a person experiences pain, maybe using some relaxation strategies or resting. We know that pain coping responses predict pain and functioning in people with MS as well as the broader pain literature or pain population. And on this slide, you will see some of the adaptive pain coping strategies in the literature, and these include ignoring pain or reinterpreting pain sensations as something not quite so problematic or threatening. So instead of thinking of pain as burning, for example, maybe thinking of it as warm. People who cope with pain by doing that tend to do better. Also, people who approach their pain with what we call acceptance behaviors tend to do better. And what do I mean by acceptance behaviors? That has to do with people who switch their focus from focusing on pain to more of a focus of engaging in activities despite having pain. And we have found that in persons with MS, those who switch their focus and kind of accept the fact that they have pain tend to do better. That doesn't mean that they are helpless, and as you will hear later, far from it, they actually are taking a lot of control, and that's what helps them probably feel this acceptance. We also know that people who use kind of coping self-talk or who say things to themselves to kind of coach themselves through a painful situation tend to do better. So things like, I can manage this, I can handle this, those types of people do better with regards to pain. And people who persist at their tasks tend to do better. And finally, we know that relaxation exercises as well as physical exercise are useful responses when coping with pain. However, there are a number of maladaptive pain coping responses. When people become less active, more disengaged, when people tend to protect an area that hurts and not move it as much as they might normally move it in everyday activities, when people become real passive or rest in response to pain, that tends to not bode well for people with pain. Another thing that I've seen in many people with MS, and this is true not only for managing pain, but also managing fatigue, is that too often when people are having a good day, when they're maybe feeling pretty energetic or not in a lot of pain, what they tend to do is really do a lot. They tend to be almost overactive to try to take advantage of the fact they're feeling well. And that's a very understandable response to having a good day. All of us would want to take advantage of that, especially if you know not every day is going to be a good day for you because of your disease. However, what we have seen is that people who have this kind of high activity on good days and the tendency to overdo it often find that they crash and burn the next day or for the next several days. And on this slide is just an example of that, where you will see where people are very active on Monday might on Tuesday and Wednesday be practically bedridden because they have an increase in pain, an increase in fatigue from overdoing it. And then they start to feel better, maybe midweek or later in the week, and then they might again do too much and then suffer for it. And we sometimes refer to this tendency, this behavioral tendency to overdo when you're feeling well and underdo when you're not, as a pacing problem. Well, what are the consequences of pacing problems, whether it's in response to fatigue or in response to pain? We know that individuals who use this type of pattern tend to learn to associate activity with pain and with fatigue, and as a result tend to become less and less active over time, and typically pain and suffering increase over time. And I'll talk more later about how to manage pacing problems. Now I want to turn for just a moment to some factors that I categorize under the term mood. As we know from this series and from research done here and elsewhere, depression is unfortunately very common amongst people with MS. And on this slide, what you see is a study where we looked at people who had a major depressive disorder, or a clinical depression, and then people who did not. And we looked to see how much pain severity they had, or pain-related disability they had. And what we found is that people with depression were much more likely to also experience severe pain and pain-related disability, whereas people who do not have depression were much less likely to have severe pain. So pain was worse in those with depression than those without. Now, we certainly know from research in a number of areas that most likely pain precedes depression. So I'm not trying to imply that the pain is caused by depression. I don't believe that to be the case, and I think the science backs me up there. But I think it is important to note that depression and pain are often co-occur, and that when they do, it often results in more disability. Also, anxiety and fear of pain can also contribute to the experience of pain. We know that when people have an anxious or fearful response to pain, they tend to have more avoidance behaviors. They tend to avoid things that might contribute to or lead to the pain. And they tend to be very hypervigilant, so they get very tuned into their pain. And we know that when these things happen, people's pain actually tends to get worse. And they tend to do less and suffer more. So pain anxiety is strongly associated with pain intensity and pain disability, and thus is often something that needs to be watched out for and intervened with. Well, as I started out earlier talking about the biopsychosocial model, you might note that the biopsychosocial model includes a social component, and I want to turn to that now for just a few minutes and talk about social support. We know in the literature that having a nice network, a network of social support, of social connections, people that you feel you can count on, people that you can enjoy things with and do things with, that tends to be good for people when it comes to their overall adjustment to MS, including their adjustment to pain. And in fact, in samples of people with MS, we see that people who report that they have good social support tend to do better than people who do not. However, there's one type of support that can sometimes get people into trouble, and we call this solicitous support. And what that means is when people offer assistance or exhibit concern mostly in response to pain. So for example, if someone with pain is sitting on the couch and says, well, I'm going to go get a drink of water, and their spouse says to them, no, sit down, I'll get that for you, you're in pain, let me do that. That type of responding to pain, although often well-intentioned, has actually been shown to not be helpful in the long term and to be associated with increased pain intensity and dysfunction. So kind of the take-home message is, in terms of support, it's helpful to be supportive of the person with pain, but it's not so helpful to always be doing things for them in response to pain. So then, just to review what we've talked about so far in my lecture, we've talked about several important psychosocial variables. These include how people think about their pain, their beliefs, how they cope or respond to pain, inactivity and pacing problems, mood, and social support. Now I want to turn for a few minutes and talk about assessment of pain. So in terms of assessment of pain, we know that pain is now seen as the fifth vital sign, and you've probably noticed if you've gone to your doctor or if you're someone who is a healthcare provider that we're always documenting how much a person hurts in our typical healthcare interaction. And often that's done by asking people to rate their pain on a 0 to 10 scale, where 0 equals no pain and 10 equals pain as bad as it can be, or something like that. And that's certainly a very important thing to do, and it's also, I'm also glad to see it's now a more routine part of healthcare. However, as I mentioned earlier, pain is very multidimensional, and thus there are a number of other dimensions of pain that are important to assess in a person with MS. And that would include the location where they hurt, including all the different regions they might hurt, the intensity and severity of the pain, or that 0 to 10 scale, the duration and frequency. It's helpful to know, does someone have pain that's severe but it's infrequent? You might treat that differently than someone who has pain that is more moderate but more chronic or unremitting. How much a person is bothered by their pain is also an important dimension to assess. So things like how bothered, how disrupted they are, their mood, etc. And finally, it's good to include measures of pain-related interference or disability. So to ask them, or to use scales that get at how much pain interferes with the person's life. So as I mentioned, in terms of pain intensity, we have our 0 to 10 numeric rating scales that can be very brief and very easy to use. It's often good to get not just a measure of kind of current pain or how much pain they have at the moment you ask them, but also their average pain over a certain period of time, like the past week, the past month. Their least pain that they've had, that gives you some indication of how chronic their pain is or how unremitting it is, as well as their worst pain for a defined period of time. Then, as I mentioned, it's good to also look at pain interference. And again, by that I mean how much pain interferes with a person's activities. And there's one scale in particular that we like to use, although there are a number of them out there, and that's the Brief Pain Inventory Interference Scale by Cleland and Ryan. And that asks people to rate on a simple 0 to 10 scale how much pain interferes with a variety of activities, including things like their self-care, their mobility, their social relationships, their enjoyment of life, their sleep, their work, etc. In an MS setting, it's also important to consider other things to measure that might give you a broader picture of how to approach the treatment of the person's pain and their suffering. And that might include a measure of depression, and asking them open-ended questions about how pain is impacting them, such as what are you doing less of or more of as a result of your pain. That might give you some clues about what's important to them and what you might want to target in treatment. Or asking what things does pain get in the way of. Questions about pain beliefs can also be important. Asking them, what do you think is causing your pain? What have you noticed makes your pain worse? What have you noticed makes your pain better? And using that to drive your treatment plan. Questions about how others respond to pain. If you have someone, if you're a healthcare provider and you have someone coming in and you hear that the family is constantly not allowing the person to do much, to move much, that's probably a signal that could be contributing, that inactivity could be contributing to their pain. And in terms of a lot of these measures I've just briefly touched on, there's a number of available toolkits and some information even on our website about assessment. And a lot of times these things could be easily incorporated into a routine practice of a healthcare provider by having the patient fill out some of these measures in the waiting room or prior to the visit. So I encourage you to think about, if you're not assessing pain more broadly, I encourage you to think about it in broader terms and to assess some of the other dimensions. So now what I'd like to do is talk now for much of the rest of my time about treatment. And as you see on this slide, this piece of art by Mark Collin is called "Hey Doc, Have You Figured It Out Yet?" And I'm just going to read to you the artist's statement that goes along with this piece, because I think it really represents some of the challenges of treating pain. And the artist says, "This piece represents the frustration both on the part of the physician and patient in diagnosing and treating chronic pain. It is not unusual for doctors to order the same test over and over again in hopes of understanding the cause of chronic pain. It also exemplifies how the patient often puts the onus on the physician to find the problem and cure it. In reality, it should be a team effort, and in many cases, there is no cure." So now let's talk about treatment. I think if there's any takeaway point from my lecture today, it's that I would really encourage you, whether you're a patient or a person with MS, a family member, or a healthcare provider who treats people with MS, I encourage you to use a biopsychosocial approach to assessing and treating MS-related pain. And certainly, even though as a psychologist I've focused a lot on the psychological and social variables, clearly the disease itself plays an important role, and medications play an important role in the treatment of MS-related pain. And I'll just briefly touch on that in just a moment. But other things are also important, and if you approach it in a biopsychosocial model, that would include things like physical rehabilitation, psychological interventions, and I'll cover a couple of those in a little more detail in a moment. It's important to really look at the social system and encourage social support, and to encourage participation in valued activities and roles. Now, there isn't enough time for me today, nor am I an expert on the pharmacotherapy for pain, but certainly there are a number of therapeutic agents out there that are used for pain, and some definitely can really make a difference in treating pain. Some of them are listed on this slide. And so again, I want to really encourage you to not take my remarks as saying you should not utilize medical interventions for pain. They're an important part piece of the management. But I really want to encourage you to also think about rehabilitative or rehabilitation interventions for pain. And this can include a broad array of things, including physical therapy, targeting flexibility, strength, endurance, and aerobic conditioning. It can involve occupational or other therapies where attention is paid to positioning and ergonomics that can contribute to pain, heat, cold pressure, massage, and really interdisciplinary approaches where a number of pain rehabilitation providers are part of a team treating the person holistically who has pain. I want to focus for just a minute on cognitive behavioral therapy for pain because I think this is an area that people are not always as aware of. Cognitive behavioral therapy is based on the theory that thoughts and behavioral responses to pain influence adjustment and functioning. And some of the common ingredients include relaxation training, cognitive therapy, and behavioral strategies. Now, cognitive therapy includes teaching individuals to identify, stop, and replace unhelpful thoughts or beliefs that they have in response to pain. So, for example, teaching someone to think when they have a pain flare-up, the pain may be high now, but I can manage this. I will get through this. Or in the case of the mom with the acute attack of optic neuritis in the middle of the night, or the acute attack of pain in the eyes in the middle of the night, when she was working on cognitive therapy, she learned to identify that those thoughts were not helpful, particularly in the middle of the night, and to use strategies to relax herself and to think to herself calming thoughts such as, it's likely an exacerbation, but I've been through that before, my doctors will help me, I can get through this, I'm likely not going to die. Those types of thoughts to help her manage her anxiety and stress, and in turn, her pain and discomfort. And she found that by really trying to identify, stop, and replace unhelpful thoughts, she was able to feel better and her pain went down. Now, there are a variety of relaxation skills people can use to relax. Those include things involving your breathing, imagining peaceful relaxing scenes and a variety of other imagery techniques. It can include progressive muscle relaxation, where a person learns to tense and release their muscles and to notice that difference in tension that can sometimes contribute to pain, and self-hypnosis training. Now, cognitive behavioral therapy, there are a number of other components, and those include specific instruction and coping skills, sleep hygiene, working with families and loved ones to help a person be as active as possible within the limits of their disease and pain, and treating depression and anxiety when present. Now, cognitive behavioral therapy can be delivered by someone with a mental health background. It's particularly important to have someone who understands MS when using CBT or cognitive behavioral therapy for pain. But also, there are a number of self-help resources out there, and at the end of my slideshow, I have a slide that lists what some of those are. So whether it's formal psychotherapy for pain or self-help, the principles can be quite useful in reducing pain and, in particular, reducing suffering. Another important way to treat both pain and distress is what we call activation or behavioral activation, which includes increasing not only physical activity, but also increasing activities which are enjoyable, meaningful, or pleasurable, and increasing participation in things that are consistent with values and goals. And so oftentimes it can be helpful for someone who's become pretty inactive in response to pain or fatigue or their MS to learn ways to safely and gradually become more active. And this is something that's often best done under the direction of a healthcare provider. But certainly trying to increase activity will likely have benefits in terms of mood, pain, and other functioning. And often that includes learning how to not do that overdoing or underdoing, but rather to really pace oneself, to kind of systematically increase activity, and to set goals that are attainable and measurable. Another way to increase activity is to use what we call quota-based reactivation, and that's where a person learns to set gradual goals that are very attainable, rather than having that kind of up and down profile of someone who overdoes it and underdoes it. And by quotas, what happens is we set kind of an upper limit to how much activity a person does to try to keep them from overdoing it. Now, there's a lot of evidence that these types of approaches, cognitive behavioral therapy, which often includes activation, are efficacious in treating chronic pain in the general population. And there have been several meta-analyses or large studies that have shown that these interventions can reduce pain interference, reduce depressive symptoms, and improve health-related quality of life. Now, we've been doing studies here at the university for the past 10 to 12 years looking at using these types of techniques in people who have pain and MS. And we saw in one study that just used cognitive therapy that it did indeed result in significant reductions in pain and pain interference. We also recently completed an in-person group intervention using CBT for persons with MS and other types of neurologic pain and found that it was also quite effective. Next, I want to talk just briefly about the use of hypnosis for pain. Hypnotic analgesia has long been thought to be an effective strategy for managing acute pain, and more recently we know it's also effective for chronic pain. And really what that involves is relaxation, focused attention, and kind of here and now experiencing with suggestions for pain relief, altering the pain experience, and decreased unpleasantness. And a colleague within our RTC, Dr. Mark Jensen, recently published a paper looking at the use of self-hypnosis where people were trained to do hypnosis at home using recordings and some face-to-face instruction and found it was very helpful in reducing pain. We also recently completed a study funded by the National MS Society where we combined both the cognitive behavioral therapy and the hypnosis in a small group of about 22 people with MS, and we found that it was actually more effective than either alone, and we're hoping to continue exploring that as a viable treatment alternative in the future. I think regardless of what strategy one tries in treating pain, I think the goal of pain rehabilitation, and I think this is a goal also for managing and treating fatigue, is to really focus on participation. And by that I mean having people do as best they can within the limits of the disease as well as with their strengths to be doing and participating in things that are valuable and important to them. So the critical question is not how or why did I get the pain, but what can I do to manage my pain so that I can get on with my life? And that is the question. The more we can help people to get on with their lives, the better they will do. And oftentimes when we help people focus on participating and on living life despite pain, despite fatigue, and despite MS, what we see is that pain reduction and symptom reduction is often a side effect. So if you can focus more on doing stuff, you're probably going to hurt less. So in conclusion then, both fatigue and chronic pain are common in MS. I didn't speak a lot about fatigue because fatigue is really could deserve its own lecture, but many of the principles I talked about could be applied to the area of fatigue, in that we know that, for example, stress is more common and depression is more common in persons who have MS fatigue, and so a lot of those similar principles can be useful. We also know that biopsychosocial factors are important not only to understanding but also to treating chronic pain in MS, and that there are really a number of interventions, both rehabilitation, pharmacotherapy, and psychosocial, that can reduce suffering and disability. And that the primary goal of treatment, again, is improved quality of life or learning to live with rather than suffer from pain. And on my last slide, I have a number of resources that you may find helpful, whether you're a person who has MS, a family member, a friend, or a provider. And I encourage you to check out these resources for learning more about pain, fatigue, and MS. Thank you.
Dawn, that was superb. Thank you very much. I'm the medical part of the team here, and I have some comments and questions, but I think I want to clarify a few points here for our audience. You know, you've heard in this presentation today about fatigue and about pain, and we heard from Dr. Bouvardier about depression in MS. Cognitive impairment in MS is coming up in future programs, and I call these really the four horsemen of MS. The four horsemen of MS, or the hidden disabilities. A person with MS can walk down the street and look just fine and have fatigue, depression, pain, and cognitive impairment, and you'll never know. And yet that can make the person's life very, very difficult and many things impossible. And I also want to point out that we've learned from our practice and from our research that these interact with each other, and I call that the sort of a new concept or a new paradigm of looking at MS. You can have a patient with these 4 problems and you can treat the pain, let's say, but not deal with the cognition or the fatigue or the depression, and they may be a little better but not as good as if you treated the depression as well and treated the fatigue and worked on the cognitive retraining. So you have to really approach these all together to get really the greatest benefit if you have these problems with MS. I wanted to ask you a question. As a researcher, how do you measure pain? I would think you can't see it on a graph. How do you measure pain?
Well, you know, there's a number of dimensions of pain that are important to measure, but certainly I think you have to take a person's word, their self-report, as valid. And in fact, there have been research studies showing that in fact, people's self-report of pain, so if they rate their pain as a 7 on a 0 to 10 scale, we know that correlates with activity in the brain in areas that where pain is processed. So we actually are starting to have, you know, physiologic evidence that is very valid way of measuring. So people used to think it wasn't, but it is.
So you mentioned that increasingly in medical visits, patients will be asked about their pain. And I know in our institution at least, and I think in other institutions, there will be little smiley faces or frowning faces, right? And if they circle this, how they feel, that's actually a pretty good indication of what actually is going on.
Yeah, we have to take what they say very seriously.
Yes, good. So from a standpoint of treating pain, I think it's also good. I want to comment just a little bit about acute pain because that is real, and patients should listen to acute pain. And as you point out, if it comes on suddenly and lasts for a short period of time, that's really nature's way of telling that patient there's something wrong someplace, so they need to seek out care. And you also indicated that patients with MS, because they're weaker and maybe have spasticity, can have other kinds of pain. And believe it or not, people without MS have pain. So all this can make it very, very difficult to sort out what's going on and how to manage it best. But I want to comment on the medical management of acute pain. So one way to think about this is really that pain is in 3 parts. There's nerve pain or neuropathic pain, and you talked about that. There's musculoskeletal pain or pain coming from the joints and muscles, and you mentioned that. Then there's something we call paroxysmal pain syndromes or spasms, and many patients can get just intense spasms. This is not spasticity, it's intense, like cramps in muscles, which can be very painful. And the treatment for one doesn't work for the other. So let me just comment a little bit. For this neuropathic pain, which is usually characterized by very sudden, sharp, lightning bolts going through the body, just incredibly intense but incredibly short bouts of pain, sharp, stabbing, burning pain. The treatments are not narcotics. Narcotics do not work in those patients, and you should not be using them. And I've seen patients coming in with that kind of pain, and their healthcare providers giving them narcotics. It just doesn't help them, and they're getting too high a level of narcotics, and of course, you know, that can be a problem in itself. But this kind of pain responds best to the same medications we use in seizures. So gabapentin, Neurontin, this kind of pain medicine works very well. Musculoskeletal pain does not respond to that. It responds to the anti-inflammatory medications like the non-steroidal anti-inflammatory medications like ibuprofen or aspirin. And the paroxysmal pain, which is the sudden cramping, is very, very hard to manage, I think, from a healthcare provider standpoint. Maybe the hardest to manage of all. And usually you have to figure out what's causing the muscle spasm. And it could be positioning of the bed sheets at night. It could be abnormal walking or abnormal gait or something, and just treat that. It's very, very hard to treat that. You know, I just saw a new production of Leonard Bernstein's Candide. And I just thought when you talked about having your mental attitude in a positive way, that Candide, who went around saying this is the best of all possible worlds, I don't think he showed much pain, and he had lots of reasons to have pain. I want to talk a little bit about fatigue. Do you have any suggestions how you would have patients manage their fatigue? I will comment on some medical management in a minute, but what about from a behavioral standpoint?
Well, I think there's a lot of similarities to how to behaviorally manage pain as fatigue as there are in pain. So, for example, having people track how they're spending their time and noticing patterns where they maybe overdo it or underdo it, trying to gradually increase activities if they are underdoing it, and looking to treat depression, stress, anything that may sap fatigue beyond what's just there from the MS itself.
One of the things we're doing in our clinic is actually ordering a lot of sleep studies for some of these patients, because patients with MS really probably do need more of that slow wave deep sleep, because as the brain sort of rewires itself, it needs that to deep sleep to efficiently do that. And sometimes because of pain or because of medications or just because of many other worries, patients don't sleep well. And you really don't know that until a patient goes to a sleep lab and spends the night being evaluated. These are really, really helpful ways to approach, I think, patients with MS. From the medical management of fatigue, the standard is a very inexpensive generic. Amantadine, taken twice a day, can help a lot of patients with fatigue. Another medication is modafinil, which is very helpful in MS patients with fatigue. And then there's a new version of that called amodafinil, which is a little stronger, perhaps, maybe a little better, maybe works a little better in some other people. The concept of providing health care to persons with MS using behavioral management is really very important, and one of the important aspects of this series is to tell our viewers about things that can be done, because it's much more than just going to your healthcare provider and getting a disease-modifying treatment. It really is important to take a long look and a thoughtful and sensitive look and analysis of what's going on in that patient's life and treat all the things there that need treatment. And I certainly hope that this program and other programs in our series has helped you, the viewer, understand the complexity of treating this disease, but that this disease can be treated and treated very effectively by using these and other mechanisms of management. Thank you very much.